Hello, everybody. Welcome to the webinar organized by the World Stroke Organization and the World Stroke Academy, entitled Stimulation Training, COVID and Beyond. I'm Anita Arsovska, Professor of Neurology from North Macedonia and World Stroke Academy Associate Commissioning Editor, and I will be moderating today's webinar. We have two experts and excellent speakers today with us. Dr. Houman Khosravani from Canada and Dr. Paula Santolucia from Italy. I would like to tell you that you can post your questions during the lectures, which will be answered during the discussion after the lectures. I would like to introduce to you our speakers today with a brief introduction. Dr. Paula Santolucia is a stroke neurologist, actual director of the Neurology Stroke Unit at San Giuseppe Hospital in Milan, Italy. She has been working in the stroke field since many years and is very much dedicated to the aspects of education and training in stroke, cardiovascular emergencies, and in general medical emergencies as certified simulator instructor and professional coach. She is the current chair of the ESO Simulation Committee and president of the Italian Society of Stimulation in Medicine. Paola will speak on how simulation training can meet the needs for safety and high performance in clinical practice at COVID time. And also I would like to introduce to you our speaker, Dr. Houman Khosravani. He is a stroke specialist with a background in neurology and internal medicine, critical care and neurocritical care. He is the medical director of the inpatient stroke unit at Sunnybrook Health Sciences Center in Toronto, Canada. He is an assistant professor in the Division of Neurology at the University of Toronto. His work focuses on human factors and neurovascular resuscitation in hyperacute stroke care through the lens of quality improvement and patient safety. His interests include leveraging system science and computation towards these goals. Houman will speak on the topic, crisis resource management in stroke care and beyond, and will explain the framework on how teams can work together to provide the best acute neurovascular resuscitation. So Houman, welcome, over to you.
Thank you very much for that wonderful kind of introduction and putting it together with all the amazing work Dr. Santalucia has done in this field. And it's a huge honor to be presenting alongside her and also at this in this venue. I'm going to just start the presentation. Okay. So the topic that I'm going to speak to you about, I have no disclosures, but we're going to talk about the importance of something called a framework, essentially called crisis resource management, which is a framework that helps teams work well together with the highest amount of performance, but also the highest amount of safety, quality, and also satisfaction of doing a good job when we're taking care of stroke patients. It's always framed such that we're focused on the outcomes, and we definitely want the best outcomes for our patients. However, those outcomes are only facilitated by how good teams work together. And having well-functioning teams and folks that are able to come to work and leave work feeling very satisfied, energized, and work together well is what allows us to do medicine well. And so this hopefully will be my thesis to you, is that crisis resource management is the way to do that, and that crisis resource management doesn't have to just be in resuscitation. It could be in the way we take care of patients all the way, whether they're in the ICU, the stroke unit, both like Dr. Santalucia and I, both of us sort of head our local stroke units, and also when they're getting ready for discharge, to be honest. The whole thing could be facilitated by some of the things we're going to talk to you about. No disclosures. When we come to a scene, when a stroke patient arrives from the ambulance or when we come to the emergency department, usually we're confronted by, a scene where there's a lot of commotion, there's a lot of stuff going on. There's also a lot of emotions that are experienced by both, obviously, the patient, who's sort of the hero undergoing the stroke, very challenging for patients, especially if they are, for example, they have a major deficit, not able to express themselves, but also the team. Sometimes patients come in and they're quite sick. Sometimes they come in immediately and they actually need to be intubated before going to the scanner. Sometimes there are other events, such as the patient has a seizure, or they are having a concomitant problem, meaning that they're having an MI or an aortic dissection, which is a major emergency, and they're presenting with neurology, which brings them through a bypass. So a code stroke, which, when we talk about the word code stroke, what we're imparting is a sense of urgency, but a sense of vigilance. And the framework that I'm about to explain, and also Dr. Santalucia's work, is to try to keep this in a kind of a calm but vigilant, state of being able to operationalize how we take care of patients and how to sort of master the domains that we're interacting with when we do this work. And so what it appears to be is obviously very busy, but we want it to be, this sort of organized chaos, if you will, rather than true chaos, which is sometimes what we all experience at our different centers. And the way to do that is, I would like to sort of appeal to you through crisis resource management. So when we think about it, when you look at a resuscitation, and that's kind of a word I would like to continue to use. When we look at a code stroke, we use the word code to make it, to impart that sense that we're actually resuscitating. And the organ that we're mostly concerned about, obviously, is the brain, which is a different end organ that's usually thought about. But we need to approach it with the same idea, the same mechanics that are run during cardiac arrests. There is no reason that these two situations are that different from each other. They both require stabilization, communication, role designation, triaging, using other systems and resources such as scanner, other consulting services. And so they're essentially the same. So I would like to impart this concept of neurovascular resuscitation or stroke resuscitation as the underpinning of what a code stroke really is all about. And words, as we know, are important. So using the right word imparts a sense of cohesiveness amongst the team. So when we look at a resuscitation, and in this case, a neurovascular resuscitation, there are 4 domains that are at play. That's the domain of the self. So the individual provider or the clinician or the clinicians need to make sure that they're okay. They're able to handle what's coming. When they're on call, they need to be ready for what may come through the door. When the resuscitation is happening, to maintain their own sense of wellness and understanding that their place in the team, but also the team dynamics, and to also feel physically okay. The team is the other domain. How does the team function? Is the team communicating well? Are they using appropriate types of language? Are they polite to each other? Are they announcing who they are? Are the roles very clear? So the team is that other domain. So the domain of the self, the domain of the team. The next is the domain of the environment. The environment which we operate in needs to be controlled. Sometimes there are crowd control issues. There might be a family member that's having a difficult time. There might be another resuscitation occurring just across the room or another part of the emergency department or the ICU. There might be factors that are important with regards to protective equipment, like right now we're facing during COVID. And of course, there's patient factors. Is the patient comfortable? Are they scared? Are they attended to? Are we triaging the things that, what's the perspective of the patient? And when we design these frameworks, when we design curriculum, I think more and more folks like Dr. Santalucia and myself would love to see more patient engagement, maybe people who have lived experience with stroke to try to help us figure out how to do these things better. But those are the domains: the self, the team, the environment, and the patient. At our center, we have a large comprehensive center. We have about 750 admissions to our stroke unit in a year, and we run somewhere between 1,200 to 1,500 code strokes. But it's only recently in the past year or two where we've started to pay more attention to this, of really calling it a neurovascular resuscitation. Our patients go to an integrated stroke unit where there are some levels of ICU care and also a ward. So the idea of continuing some of these principles upstairs is very important. In the before times, we were thinking about door to needle. Obviously, that's being a bit facetious. We still work, think about door to needle or door to groin, door to intervention. But obviously, top of mind recently has been freezer to needle times with vaccination. But door to needle times are still the most important thing. And to fix that, we need high functioning teams. The arrow of time means that the team has to work together very well and efficiently, because as we all know, patients have different rates of progression. Now, sometimes patients are coming from another center, sometimes they're being flown in, sometimes they're being driven. There might be weather factors. So in the arrow of time, we know that the neuronal loss, as shown recently, could be somewhere between 35,000 to 27 million neurons a minute. So time still matters, not only when they're coming to us, but also when they're in the building. And that's where crisis resource management and simulation really matter. The idea is to get door to needle times under 30 minutes, as our audience well knows. And the guidance is that most 90% of these cases should have it done under 60. So in the crisis resource management framework, we at our center have been using crisis resource management to lower our door to needle times. And that's one of the things I wanted to talk to you about as well. The number needed to treat for TPA is still super good when it's given very quickly, and so it's very important to know that the number needed for TPA is around 1 in 5 when it's given within 30 minutes of arrival, and so it's quite important when they're within that time onset of 30 minutes to within 3 hours, and the system works well, that they're able to get really good outcomes. And of course, now with thrombectomy and the trials that are yet to be published and completed, suggesting that in the right case, in the right time, if the angio suite is ready, the patient has a large vessel occlusion, there might be room for patients to go directly to angio after some imaging or get imaging in the angio suite. Working together as a team is even of more importance. So we're moving from a concept of door to needle to door to intervention. That's another kind of thing I would like to impart to say door to intervention is really important. I'm just going to share with you some of the issues we've had at our site. If you look at data from 2015, 2016, 2017, 2018, for a large center, our door-to-needle times were around 40 minutes, somewhere between 40, 49. These are median times. And so we, from my perspective, when a patient comes in, and from all of our collective perspective as a stroke community, we don't want it to be a flip of a coin where sometimes the system works well and sometimes it doesn't. The background of the slide is literally a coin flipping on a table. And so if you think about the factors that matter, it needs to be signed, sort of safe, timely, effective transfer of the ambulance, cohesive handover and stabilization of the patient, and initial assessment with the NIH, going to the scanner to get a timely CT scan, followed by communication amongst the team of what are we going to do next? Is this person a candidate for intervention? And to get that door to intervention time down as fast as possible and as safe as possible. And so, despite all of the things that we can do, communication, pre-briefing, early handover, getting their electronic record, having a family collateral, we can call the family even before the patient arrives. At the end of the day, we know from quality improvement work and research and science that the most important thing is not the individual change ideas, but it is the culture of safety and quality in our emergency department, the culture in our stroke unit, the culture in our stroke program. And so there's a famous saying that says, culture eats strategy. And so this slide reminds us that culture is really important from Peter Drucker. At our site, much like your sites, we have quality metrics and quality goals, and we have actually put quality culture on the map as one of the pillars of kind of strategic planning. And again, with the privilege that we have and I have right now of speaking to you in a more global audience, I think it's important to put the culture and a culture focused on quality, safety, teamwork as one of the pillars of strategy for your local stroke environment. And so sometimes when we try to come up with ideas of what to do, we rush to a solution, such as, can it be done by fixing this aspect or that aspect, whether it's in simulation or the system itself. But we need to always take a step back, and as Dr. Santolucia will also discuss, and I will discuss, we want to talk about debriefing. And so through the art of debriefing in every situation, we change the culture, we figure out how to work synergistically with other programs. So for example, if your site is a trauma hospital, then trauma and stroke are sometimes always together, meaning that we are looking for the scanner at similar times, we're operating at night together, they are using resuscitation areas together. And so looking for things like synergy are perhaps, and also through debriefing, are ways to move forward rather than trying to pick one specific aspect of change that may be good for stroke but bad for another program, for example. Same thing if you're a cardiac program, by the way. This is an example of what we do and others do in the context of quality improvement. So I'm showing you the framework of our problem and then how we try to implement crisis resource management. We did what's called a process map of what happens when a patient enters the hospital from a different pathway, how are they triaged, what happens, and who are the different team members that do different things. So essentially, obviously it's a very busy slide, but what I'm trying to show is that there is the concept of, it almost looks like a circuit diagram, and the key thing is to kind of measure the voltages, if you will, between different points of this circuit. Where are the problems, where are the bottlenecks, where are there safety issues, quality issues, and can we leverage things to help these problems? And what I would like to, which we're going to be getting to, is the idea that crisis resource management helps team members operate in such a high level of performance that the human factors, at least, can be taken care of at different points of a process map such as this. So at our site, for quality of door-to-needle improvement, door-to-intervention improvement, we wanted to make sure that we had good identification and pre-briefing. We wanted to make sure that we have rapid drawing of blood work and registration and order entry, and then the CT scan knows that we're coming, almost like an airplane landing at an airport. We know which gate we're going to. The gate knows that we're about to come and arrive, and to fix those processes. And what we realized was, we all of these are human factor driven. I really like this slide because, as you can see, we have things like partners, safety, efficiency, effectiveness, but you see this beautiful blue box, compassion. We need to show compassion, not just for our patients, we need to show compassion for ourselves. Right now, we're all emerging from COVID-19's very challenging time. We need to always remember to be nice to each other at work. When things don't go well, give each other a break. And again, through debriefing, through discussions down the line, these are ways we can do that. And of course, this together builds that green square, which is the culture of quality and safety. For example, for the pre-brief, so remember that that circuit diagram, we identified that in one part we could intervene was pre-arrival. So we came up with a very quick checklist. If we know a patient is coming and we have some information, we pre-hand discuss who is going to be the code leader. We've already actually decided that first thing in the morning, who is the code stroke leader. But in the emergency department, we get to know who is the primary nurse by name, who is the circulating nurse, who is the person registering the patient. Is there any relevant history that we know through the phone call? Are they going to be a TPA or a thrombolytic candidate or not? Is there anything, do we need to weigh this patient? Have they already received thrombolysis? Have they, are they on a warfarin and they don't need to be weighed? Or, warfarin may be not the best example because it's going to depend on the INR, but are they on a direct oral anticoagulant and we know we're not going to be giving thrombolysis? This moment of getting the team together, knowing people by their first name and introducing each other is really important. It takes about 30 seconds, but it makes a big difference when we're able to look at each other and say, hi, I'm Houman, I'm going to be the code stroke neurologist. Oh, hi, David, another name, Nancy, can I help you? How can I help you? Or are you going to be looking after the IV? Thank you. Okay, and so on. If we know what our roles are pre-hand, all we need to do is to then go ahead and specify knowing each other's first names and just going and doing that work. Before we go to CT, we also have a quick checklist that we run. We make sure the patient's airway is okay, we have IV access, the correct tests have been ordered, CT knows we are coming. I really like the idea of thinking about it as an airport. Patient lands, you need to know where to go. Do they know where we're going? And are we safe to travel? And as you know, there's always a bit of a rush with door-to-needle interventions, or excuse me, door-to-intervention. But what we need to do is slow down and proceed cautiously sometimes. If the patient's unstable, there's nothing wrong with ensuring the patient is fully resuscitated and fully okay, because it's never good for the patient to have a code, cardiac arrest or some sort of airway issue in the scanner. And I know this is obviously very intuitive, but sometimes we have to remember that the old saying that comes actually from the Navy SEALs is that slow is smooth and smooth is fast is a very important concept. And I think that is something that we should think about. And these checklists very briefly allow us to do that before the patient arrives and before we go. And we iterated on these through cycles of PDSA. This is the data at our site before COVID sort of caused some changes. But you can see that we were in the 40s, 40-minute door-to thrombolysis over many, many sort of months. And you can see that when we, for example, instituted our pre-arrival checklist with different versions of iteration, and we started to do debriefs and get the whole system to kind of work better, that we got a persistent reduction in door-to intervention times, essentially under 30 minutes for a median number. And of course, we fluctuate, much like work-life balance, we fluctuate, and COVID caused obviously massive changes initially, but we're still able to sometimes now get even under 15 minutes, even during COVID, in the right cases. So I would like to now show a video from someone that I look up to. I don't know this person personally, but obviously it's a story that we've all heard about. It's the story of Captain Sollenberger, who was the pilot, an experienced pilot, who landed the aircraft, believe it or not, 12 years ago now, on that fateful day on the Hudson River in New York, when that plane lost both engines. And this is a very good segue for two reasons. One, crisis resource management comes from aviation. It comes from something that used to be called cockpit or crew resource management, and it's still practiced in all civilian and military aviation. It's also used in aerospace. The astronauts on the International Space Station use it on a daily basis. All of the teams that do fire, rescue, medevac, all of these folks talk about crisis resource management. And in medicine, we are talking about it, those of us who love simulation, who are steeped in simulation, but we want to get the message out to neurology and the broader stroke community that this framework is helpful. And so I want to show you this video from Captain Sollenberger, and I want to show you some of the aspects of crisis resource management that he emphasizes, such as communication, situational awareness, triaging, and also teamwork. Let's have a listen to this video.
January 15, 2009 started just like 10,000 other days, literally. This was a large flock of large birds. The species Canada geese, they weigh 8 or 10, sometimes 12 pounds. They have 5 foot or 6 foot wingspans. And they struck the airplane along the leading edges of the wings, the nose, and into the center, the core of both jet engines. Immediately I could hear terrible noises from the machinery being damaged I'd never heard in an airplane before. I could feel terrible vibrations I'd never felt in an airplane before. And then the thrust loss was sudden, complete, symmetrical bilaterally, both engines at once. It felt as if the bottom had fallen out of our world. And my body responded immediately in a very normal human way to this sudden life-threatening stress. I was aware of that as it happened. I could feel my pulse shoot up, my blood pressure spike, my perceptual field narrow in tunnel vision because of the stress. I remember vividly my first 3 conscious thoughts. This can't be happening. Followed immediately by a realization that unlike all those other flights I'd had for 42 years, this one probably would not end on a runway with the aircraft undamaged. And I was okay with that. But because I had learned my craft so well, I knew my airplane and my profession so intimately, I could set clear priorities. And so I chose to do only the highest priority items. And then I had the discipline to ignore everything I did not have time to do as being only distractions and potential detriment to our performance. You see, I'm also well-read, and so I knew the neurobiology. I knew that multitasking is a myth, that when we think we're multitasking, what we are in fact doing is switching rapidly between tasks, not doing either of them well. And so I chose not to try to do too much. Within a few seconds, by memory, I had taken the first two remedial actions that we would eventually get to on the checklist over a minute later, over a third of the way through the remaining flight time. But I needed those actions to be effective immediately and not to wait. Our first officer, Jeff Skiles, couldn't have had a better colleague that day or since. So he made an important suggestion at several points in the flight. He was silently cheering me on as I made each decision, but ready to intervene to check my performance if he thought I was making an error. I had a chance to make only one announcement in the cabin, and before I made what I knew would be the most important PA announcement of my life, I took what was probably an extravagant amount of time, 3 or 4 seconds, to choose my words very carefully before I spoke. I wanted to sound confident, not agitated, because I knew that courage can be contagious. Fortunately, we have the advantage of having a very well-defined and very concise aviation vocabulary in which there are certain single words that are rich with meaning. Brace is such a word. And in the spur of the moment, I chose another word to give the passengers and crew in the cabin alike a vivid image, a word picture of what to expect. So I knew it was going to be a hard landing. I just didn't know how hard because Jeff and I had never practiced this before. So I chose the word impact to give them that vivid image. I said, this is the captain, brace for impact. And right before the landing, I asked Jeff Skiles a question. I said, got any ideas? Now, some think that was a flippant remark, but it was not at all. It was just an indication of how deeply internalized these team skills are that I used to teach. I was saying to him, and he understood in context exactly what I meant. I've done everything I can think of that can help us. Are there any other actions that we can take that you can think of that would help us succeed even by a fraction? And Jeff's answer was, actually not. And he answered just like that. Not at all because he was being insouciant or not because he was resigned to an ineluctable fate. Far from it, we were fighting to save every life to the very end. He answered that way because he knew we'd done all we could. The fact that we could have that exchange just before the emergency landing of a lifetime is one of the more remarkable things about this flight and this crew and our diligence, our dedication to never give up, to try to save every life, to do everything we possibly could.
Wow, so just such a wonderful, I mean, it's, I've seen this video many times and it's slightly edited. It goes obviously to the creditors, the folks that came up with the interview. But you learn something every time. I just want to highlight some of the things he said. So if you think about sort of how it started, he immediately recognized his physiology. He recognized that I am in a very stressful environment. This is about to be extremely a challenging situation. He then recognized that he could not multitask. He recognized that what he needs to do is to focus on doing what he is well trained to do and to execute on that in a very meticulous way and not to try to do too much. He then communicated very effectively to his partner and also to the cabin, choosing words very carefully, very meticulously. And then there's many things in there, but he also had a calm exchange with a team member in a time of severe crisis. Is there anything else that we could be doing? Are there any other ideas? So if you think about it, Sure, we all encounter code strokes that are super easy, low NIH. There might even be a bit of a TIA. But we need to always be prepared and trained to the level of a very sick, complicated, unstable, or patient that may get unstable later level of vigilance, but also teamwork. And by doing that all the time and debriefing about it, we can then just make it be so natural. And so these are some of the things I'm going to sort of talk about now on CRM. So as mentioned, it was started really in the 1970s in aviation. It's used by all of the fields I talked about. Within medicine, our colleagues in anesthesia, critical care, and emergency medicine teach it in their curriculum. Now, if we are blessed to be in centers with experts like Dr. Santalucia, where there is, this is being done routinely, then that is fantastic. But there are so many neurology settings where there is sometimes no simulation or crisis resource management built into the training. I'm talking about residents, medical students, and nursing teams and physician teams, or folks that are kind of in different spectrums of practice. And of course, doing it in isolation, even amongst the physician teams, for example, in anesthesia, is not going to be as yieldful as if we are doing it together with different members. And so there's parts of this that need to be done in simulation together, and there's parts of it that can be done before simulation, almost mental preparedness and understanding of the framework of how to approach it. And let's talk about that. So these things, this framework of crisis resource management, are a series of non-technical skills. They're sometimes called soft skills, but truly, these are the skills that make you be the most efficacious. So maybe the better word is really non-technical skills, because you're not trying to do a procedure, but what you're trying to do are sort of human factor skills. And maybe that's better. Human performance skills may be a better word. And so this framework is what we're talking about. We know that medical error is a big problem, and we know that when things go wrong, it's a situation where a bunch of things line up the wrong way and cause a problem. And this is the famous Swiss cheese sort of dogma of Dr. James Reason. But you can see in there, these are the factors that were identified many, many years ago. Technical factors, system factors, teams, organization, culture, and incomplete policies, including things like distractions, training, and fatigue, going back to the domain of the self. And so these are the things that can sometimes all come together to cause harm. So for example, that patient that comes in with a stroke that, tens of minutes later we discover is actually having an aortic dissection or a massive MI, and it wasn't very evident, or they're in septic shock, and they're having a stroke still. And now what do you do? Or a trauma patient that comes in who's not talking, who may appear they're confused or have a toxic syndrome on board, but in fact are having a large vessel occlusion. So when it matters most, it really brings together these skills that we're talking about. These are the pillars of crisis resource management. Situational awareness, as you heard in the video, being constantly aware and reevaluating what's going on. Triage and prioritization, understanding that I can't multitask, you can't multitask in these situations. And by all of us realizing this, we can be aware of not adding additional cognitive load to each other. So for example, if I'm for example, a clinician talking to the doctor or another clinician, and I can see that they're busy, they're trying to get an IV, they are trying to order a test, unless what I'm about to communicate is super important and about the change management, maybe we can hold off. Maybe some of the conversations we have during the resuscitation should really be prioritized based on what is actually going to happen. And those communications should be polite, using people's first names, and using a closed loop. So for example, can you please give 500 cc's of normal saline and please let me know when it's done? And that's a closed loop. And reading back, I'm going to be giving 500 cc's of saline, I'll let you know when it's done. Very simple, tight conversation, but very clear. Being aware of each other's cognitive load is super important. These situations, there's a lot going on, plus the stroke team is trying to decide what this patient is a candidate for. Role clarity, if another person comes in, who are you? Introduce yourself, say what your role is. Also being able to communicate when the code needs to be paused because the patient's unstable, to really say that. Hi, we're going to, this is the stroke team, I'm Houman. This code is right now on pause because the patient is unstable, we're going to resuscitate this patient first, and then we will resume decision-making with regards to stroke. Vocalizing that, asking if there are any other suggestions from the team, and everybody understanding that this is how we talk, this is how we do things. Imagine all of us talk this way, it will make a much better system. And the point is, we don't have to invent it. It's there. It's there. It's being practiced every day. Hopefully all of us will go back to traveling across the world and seeing each other. The reason we're able to land 100,000 aircraft safely most of the time, like essentially, as you know, the record is very good, is because they use the crisis resource management framework. And right there, not to be at the bottom, but it's how it all comes together: simulation, simulation, and debriefing. Now, it's hard to get everybody together for simulation sometimes, but debriefing after a situation, whether it went good or bad, is a good way to learn in situ when it's happening, and that way we can learn from the experiences. So that really good EVT, we had a really good outcome, patient came through, everything went well. Quickly come back to the emerge, take 5 minutes, talk with the key people that were involved. How did it go for you guys? And how did folks feel? Could we have done anything better? In a non-judgmental, in a very open way. And so we have to be aware of these. Like, if we don't have this framework, then we can't be open to the cues coming from the patient. We may miss something that the patient is trying to tell us, whether it's physiologically through their exam or through some other piece of information. This is very common. This happens during points of handover, where, for example, the patient is coming as a stroke, but somehow that's not communicated, and it's thought that they're coming in for another problem, or vice versa. The family says that I think they're having a stroke, but during transport it comes in as a MI or sepsis or delirium, and then it ends up being a stroke, but it's detected later. So having, again, a framework where we don't task saturate, maintain our cognitive load, communicate effectively, allows us to be open to those cues. And again, as team leads, those of you, all of us in different team leads at different times, we need to be aware of that and be mindful of how is the team working. And so that's very important. This is just to show you there's a bit of science in this as well. This is from a book called On Combat and found on the EMCRIT website, emcrit.org, where the full references are. Where in law enforcement, it's known that as people's heart rates escalate, that is, again, there's science there to show that we lose different abilities. So for example, if someone's very sympathetically driven as a provider, a clinician, they lose motor skills. They can lose complex cognitive thinking. And so there needs to be a conscious effort for us to remain in a calm state of vigilance. And so what I like to call this is that we like to maintain a condition yellow. So when I go on call, and this is kind of what I'm trying to say kind of in part, I'm not stressed out, but I'm also not completely calm and parasympathetic. I'm in this calm state of vigilance. And this is kind of what I've arrived at after kind of looking into this and looking at what we do as teams. And this sort of condition yellow has been used in fact by other teams in the military, like the Navy SEALs, where they maintain a calm state of vigilance, remembering that to sort of be able to actually execute on that. And that takes training, that takes time, it takes meditation about what could I experience when I'm on call, so that when that, your shift change is about to occur, maybe you're on an overnight shift, right before there's a code stroke, and guess what, that person deteriorates, we're not ready because we weren't thinking, oh, that's not gonna happen, I'm almost done my shift, nothing's gonna happen, right? And so not being stressed out, but being calm and vigilant is important. And so this is where it kind of gets into the idea. During the actual resuscitation, prioritization of the medical tasks, what do we actually need to do? Sure, we need an IV and so on. Do we need to change their gown? Do we need to do an ECG right now? Can we do it as soon as we get back? Let's not forget to do that, but what needs to happen? Do we have the monitor connected? Do we need to measure another blood pressure? The blood pressure is measured by EMS, emergency services. The patient is now on a stretcher, it's the same blood pressure. Let's just measure it next time in the scanner if we don't need it. So being aware of these things is very important by meticulously thinking about it and doing it during simulation. And the colleagues of mine, Cliff Reed and Scott Weingart, published a paper called the 0-Point Survey, and I want to share that figure with you. We worked together to implement this paper into stroke, and it's published in Neurocritical Care. And I want to just explain to you what it means. It's called the 0-point survey because it happens before anything happens. It's the 0 point. And so you heard even Captain Sullenberger talk about his physiology, his reaction. But because he had prepared for this many times in a non-emergency, he's thought about, how will I react? How will I keep my heart rate down? How will I control how I feel? How can I help my colleague maintain a state of calm? He was able to do it. And so the 0-point survey has an acronym: step up to the resuscitation. The step portion occurs before the resuscitation, before the patient arrives. And the red area is where the resuscitation is occurring. So before anything happens, are we ready? Have we had something to eat when we're on call? Have we taken a break? Have we made sure we've gone to the washroom? It sounds silly, but these are real things. Have we introduced ourselves to the team in the emergency department? Should we go down and just say, hi, I'm the stroke lead tonight. Can I just know who some of the folks working? And if you're in a small center, you may know everyone. If you're in a large center, you may not know everyone. There's nothing wrong with going down and introducing yourself before the code stroke comes, knowing their names and being ready. During, understanding that the room is ready, that there's good lighting, crowd control, PPE, things like that. And then when the patient arrives, we can do the survey. Are they stable? Quickly, NIH stroke scale. And then during that assessment, constantly repeating the analysis, sharing the model if the patient deteriorates. For example, if the code goes in a different direction, the patient's unstable, it's totally okay to pipe up and say, patient is now changed. We believe there is something else going on. We're going to put the stroke imaging on pause while we address this. Any questions from any team member? Okay, thank you. Emergency physician or colleague in other specialty, you are now primary. I'm going to remain, I'm available to your help. Very simple, but using that language helps a lot. And so sharing the mental model as we unite for the same team goal towards the trajectory of getting the person, the patient, to imaging and assessment to deliver treatment is really key. So as you can appreciate, this doesn't, like, you're not going to every code is not going to be as intense as what I'm describing, but using these principles will make sure that you are ready for the entire spectrum of what comes through the door, and that you don't need to invent this framework. It is already there, and it's being used in these disciplines. And so I do want to come back to what I said about this idea of slow is smooth and smooth is fast, and recognizing this idea that Professor Kahneman, who also just wrote another book, talks about, which is system 1 and system 2 thinking, reactionary and deliberate thinking. Reactionary is when we act without thinking a lot about stuff. That's sort of system 1. But as we get more experience, as we refine our thinking, our framework, system 1 thinking is not always wrong if it's being done by the type of person that is now more of an expert in what they do. But as we all are training and building our system, especially for our residents and medical students, their system 1, which is their reactionary, can be more task challenged and more challenging to do it in a good way. And so it's really important to slow down and to think and to have a meticulous approach to how we proceed with resuscitation. So this concept of what I'm talking about is, as we do residency and even into staff lives during COVID now, we are in medicine naturally sort of stress inoculated. We're steeped in these stressful environments. And what I'm talking about by using crisis resource management is to remember these pillars of triage, communication, role designation, be aware of your own cognitive load, your colleagues' cognitive load. Put this into the framework of the 0-point survey, and then when the resuscitation is occurring, to reassess, to communicate, to triage, and so on. And this allows us to build a team that all of us share the same principles and we work together very well. And it takes stuff like this, putting it together where we actually are designated where we stand, who does what, so that it is more protocolized as much as possible so that it goes very smoothly. This is a bird's eye view of our resuscitation room. We have, during COVID, we implemented the protected code stroke. So the one physician does the assessment, there's 1 or 2 nurses in the room, the patient with a mask on them, and there's a safety lead to make sure PPE goes on correctly, registration, and then we travel and we run those 2 checklists, especially the departure checklist before departing. And by the way, we're happy to share all of this with your centers. If you're looking for any of this information, I'll work with our World Stroke Organization and World Stroke Academy colleagues to share this information with you. Just finishing up my talk, my portion of this curriculum that we're doing with Dr. Santolucia and myself, this concept of debriefing and the concept of a hot debrief. So it's not this prolonged 1-hour sit down, assessment of what happened. It's returning to the emergency department or going to the angio suite or going upstairs to the ICU and saying, hey, team, can we do a quick, hot debrief? And someone will say, hey, what is that? Well, we're going to talk about 5 minutes in a non-judgmental, confidential manner about what went well, how did folks think things, that we were successful as a team, and how were we not successful as a team. And the more we do this, these hot debriefs, we can use these opportunities as little mini simulations that are real life to learn, and of course do proper simulation like you're about to hear, so that it all comes together in a good way. This framework is also in that neurocritical care publication. It talks about initiating safe space review, participation by all, and follow up. And of course, if we implement things we learn from these hot debriefs, we can make those, as you heard also by Dr. Sullenberger, by Captain Sullenberger, those small marginal gains, those small incremental improvements. So the overall takeaway points is that we have adversity in what we do. We are sometimes in a tough environment. Code strokes can be very relaxed or super sick patients. And the way to deal with that is through crisis resource management. I hope that I've convinced you that it might be useful. And to be aware of distractions, to be aware of our own cognitive load, our own physiology, and to be in this calm state of vigilance as we all go on call to take care of our stroke patients. So with that, as you recall, he said, courage could be contagious. And I think that's really important. And so, and maybe we can say culture can be contagious as well. And so a culture of quality safety is super important. With that, I'll end by just highlighting some of the folks that I work with. There's a lot more people now that are part of this, but we have acute stroke coordinators. A lot of this was done by folks like Sandy, Joshua, Fujan. I work very closely with our regional program director, Beth Linkowich, for our regional stroke program. She's been tremendous in supporting all of these changes, and the folks that are part of our teams, including critical care nurses that come to our code stroke resuscitations. Catherine Convery is our quality improvement and performance specialist, and all of our colleagues in critical care, diagnostic imaging, the CT technologists, emergency medicine nurses, the folks that register patients, all of the folks that we work together. This is kind of a shout out to all of them, as we don't work in isolation, we work in a team. So with that, thank you for your attention and your time.
Thank you, Houman, for the excellent presentation. And now we move on to our next speaker, Dr. Paula Santolucia. As I said in the beginning, Paola is a stroke neurologist, actual director of the neurology stroke unit at San Giuseppe Hospital in Milan, Italy. Paola is here with us today. However, we will play her pre-recorded lecture entitled How Simulation Training Can Meet the Needs for Safety and High Performance in Clinical Practice at COVID Time. Paola, over to you.
Thank you very much. I'm very happy to be here with you today talking about simulation training in stroke, generally speaking, and particularly at COVID time. I have no disclosure, and please see here the outline of my presentation. I will briefly talk about standard of stroke care before COVID-19 and simulation experiences, stroke and COVID-19 in terms of new paradigm of care, changes, challenges, and demands, simulation training in the new normal, experiences and expectations according to simulation training, and take-home message. Whoever works in the stroke fields knows that we have spent years with trials and errors with the aim to reach standards about actions and critical thinking in a very narrow time window for stroke care. And especially in the last few years, we have reached a global standardized pathway that comes from the discussion around organizative models such as hub and spoke or whatever model works according to geography and logistic. The definition of a specific pre-hospital stroke code, the connection and the continuity between the pre-hospital stroke code and the in-hospital stroke code in terms of a very strict sequence of actions coming from the pre-notification, the direct transportation to CT scan, where it comes the clinical decision and selection of patients also for endovascular treatment, priority lab for blood tests, and eventually the treatment with IV thrombolysis at the CT scan. Also, we have been working a lot for strict protocols of care in stroke unit. In order to achieve a high level of performance and safety, both in the standardization of the processes and in the proper implementation of the connected actions in many stroke centers, and I would say in the majority of the stroke centers, also thanks to the ANGELS initiative promoted by the European Stroke Organization, the World Stroke Organization, and embraced by the majority of national stroke organizations, training by simulation has a main role, particularly the so-called in situ simulation. I am sure that you are all familiar with the technique. I can briefly say here that this kind of simulation is the one training system able to discover any latent and potential pitfall in the system related to teamwork and abilities and to any possible environmental issues. Thanks to the in situ simulation programs, we were able to improve pre- and in-hospital flow of standardized actions. We shorten in a significant way door-to-needle and door-to-groin. We improved the interdisciplinary team communication. We were able to discuss management of difficult cases, to empower the standardization process, decisional process, and the clinical judgment, for example, through the use of specific checklists, process monitoring, steps analysis, and debriefing. And we overall achieved a very good quality and safety system of care. And for sure, we have the tools to shoot any system pitfalls. The COVID-19 pandemic affecting all parts of the world is having huge implications for stroke care. The World Stroke Organization, since the beginning, has been monitoring the impact of the pandemic globally, as it is addressed in this paper. They described an initial fall in stroke patients' presentation to emergency departments and a widespread impact on stroke services. And these issues have been addressed from many centers worldwide. This is a report from an international panel of representatives from 18 countries, and it is the result of widespread sharing of experiences worldwide. It represents a best practice guidelines that provide guidance on how to treat stroke in the context of the pandemic while safeguarding healthcare workers. For example, here we have a flow chart suggesting strategy to minimize exposure from COVID-19 infection during evaluation of stroke patient. As you can see, it is important to identify a designated area or a pathway for infected patient, and of course for every healthcare worker to wear the the personal protective equipment. Here is just one of the many proposed workflow of hyperacute stroke care in the era of COVID-19 pandemic. I'm not going into the detail of this workflow because this is not the purpose of my presentation. I can tell that in the standard of care, now we have a few new steps related to the early identification and separation of confirmed and suspected COVID patients. According to this, we need to think about new strategies of management. For example, the use of telemedicine for TIA assessment or minor stroke, or also new protocols in terms of diagnostic. For example, how to manage a concurrent brain CT scan and chest CT scan for suspected COVID patient affected also by stroke. In a word, we need to ensure that the highly effective stroke therapies that we have today continue despite the service reorganization and the burden of the pandemic on the stroke management. This slide shows also a flow chart from one Italian stroke center, and as you can see, the main point is to separate the pathway between suspected COVID patient and COVID-free patient. Also in this hospital, they equipped a mobile CT scan outside the hospital in order to have the patient have the CT scan, the brain CT scan, and also the chest CT scan. However, the main point again is that in the new protocols, in the new pathway for management of stroke, we need to think about how to pre-select patient suspected for COVID in order to address them to the proper pathway, and also to admit them to specific dedicated COVID-19 medical ward respect to the ordinary stroke unit. So what are the changes, the challenges, and the demands in this new situation? We all faced with healthcare system and models reorganization, reduced the contraction of the resources, less doctors and nurses, and also resource replacement. We all know that also stroke doctors, stroke physicians and nurses have been put in COVID unit instead of regular working stroke unit. And also the stroke patients have been centralized in limited numbers of centers. Many in-hospital units have been transformed. Many stroke units have been transformed in COVID units. We also have adopted new hospital pathways and protocols, and first of all, everyone is using the PPE, the personal protection equipment. Pre and in-hospital acute stroke pathway have been remodulated according to COVID patients' algorithms and management. So we had a need for urgent new checklist and flowchart. The diagnostics and the therapies have been delayed, and also we had and we still have to face the management of stroke in COVID patients. There was an overall marked reduction of stroke patients' access to emergency department and a global impact on stroke care paradigm and patients' outcome. Why I'm showing these pictures? These pictures are coming from a different environment than healthcare environment, the military and aviation environment. They are preparing for exceptional situations such as a war, such as a sea landing. We were not prepared for our healthcare war, the pandemic, the COVID-19 pandemic. What I always say when I talk about simulation, I always say that the military environment, the aviation environment, and the healthcare system share a common classification. We are all high reliability organizations. That are organizations that succeeds in avoiding catastrophes in an environment where normal accidents can be expected due to risk factors and complexity. And we are in the need and in the position, in the role and responsibility to build up a reliability pathway that is a dynamic process to prevent errors and failures, and also the capacity to cope and recover quickly should errors become manifest. How to reach this target? Through highly trained personnel, to continuous training, to effective reward systems with frequent process audits and continuous improvement efforts. And as Einstein said, learning is experience. Everything else is just information. So our main point is to build knowledge through experience, to build new pathway, new protocols through experience. And the only way to manage this kind of attitude, this kind of habit, the only thing to create this new pattern, this new paradigm is through simulation training. That is the training, the master training that comes from experience. Simulation training helps with the strategy planning and the new pathway. It tests the system especially the in situ simulation, and resolve any evident or latent problem. Speed up the processes for time-dependent diseases in a globally delayed system, such as the context of a pandemic. Reinforce the safety of the whole system for healthcare operators and patients, for example, through improved technical skills and new habits in old standards of care and build up a stroke-ready center in this new normality due to COVID-19. Here are some examples, some pictures of in situ simulation at COVID time. As you can see, first thing, the patient, the triage of patient is in a outside location from emergency department. The emergency department was remodulated in a context, in a room where you can triage the patient for and test him for the COVID-19. And the second thing that you can note is that the healthcare workers are wearing PPE. Here are other examples of simulation, in situ simulation run within the Angels initiative. Here is in Italy, and some other examples from Europe, from Portugal and from Spain. So the situation is the same. However, also the conclusion is the same, that in-hospital simulation works, and so you get fast, out and test and validate all these needs. This paper describes the application of simulation for improving stroke care at times of the COVID-19. The group is from Calgary and used in situ simulation to identify latent safety threats and to adjust institution-specific protocol. Practice your protocols. And as you can see from this slide, they focused on insufficient communication. The consequences are failure to initiate necessary code stroke. The impact of simulation is practicing of acute stroke communication, also in patients with respiratory distress, so also in this COVID situation. Or, for example, the practice on how to wear personal protection equipment, the donning, doffing PPE. The consequences are risk of infectious exposure despite available PPE. So practicing donning and doffing of PPE also in emergency situation. And so on. With in situ simulation, you can test whatever you like, going from individual skill abilities to system situation, system issues. This is another example of application, of virtual in situ simulation, which has the advantage to reach as much learners as you want, and you can use in this way very easily the digitalization of the learning. Here is another experience, also another example from Canada, also another Canadian experience. These organizations provided with simulation centers that reported an overbooking activities to develop and refine, for example, new spaces and new models of care for COVID-19 patients, or to test, to ensure individuals and teams in terms of following the safest clinical protocols and procedures, or for example, how to practice safety in this emergency pandemic situation. And they mainly worked in simulation centers. And as I said, this is a common report in literature. The simulation centers at the time of the pandemic were overbooked because there was a high request of testing many skills, especially on how to manage emergency situation of specific disease in COVID patients. Here is another example from Ireland, where they are running an in situ simulation with a mannequin. You can do also this, and the effect, the results, the outcome of the simulation would be the same. They can test the protocols, they can discuss clinical cases, and allocate resources. So the take-home message based on this discussion is that simulation training is the answer to the increased safety and performance demand that comes from the healthcare system in a pandemic time. The in situ simulation training is strongly advised in acute stroke management to ensure a level of care as close as possible to the standard one. And the benefit gained through simulation education and training in COVID-19 time will last longer. It will empower the future normal standard of care. I thank you very much for your attention, and I wish for you and I wish for all of us that we can always even more and always more change our mindset and build a simulation habit, especially at this particular time. Thank you very much.
Thank you very much, Paola. Your talk was really very interesting and inspiring. And due to the time limit, I think we will have a couple of minutes to answer one question each speaker. So I will continue with you, Paola. There is a question for you. What is the evidence of the effectiveness of in situ simulation in terms of higher performance and safety?
Thank you, Anita. It's a very nice question. Actually, the evidence, we don't have the evidence in the classical mean of evidence in medicine. We are use of evidence coming from randomized controlled trials. We don't have RCT for simulation, but we know that simulation works. Because as also Houman said, once you have in habit doing simulation in your clinical practice, the safety, the overall quality and safety of the system, of the team working, the ability, the individual ability will improve in a tremendous way. So simulation inevitable will increase your performance, your capabilities, and especially your abilities to cope with errors, because you build a new culture, a new habit, the habit to learn from errors, is a safety attitude in contrast of the old blame attitude. So this is the most important evidence in our real life. That's why I talk about simulation habit.
Yes, in line with this question, there is another question for you and also Houman. Have you tried virtual simulation during COVID? You can go first and then Houman to answer this question.
Virtual simulation during the COVID time. Virtual
Yes.
simulation, we have in literature and also in practice many examples of virtual simulation, because virtual simulation had the advantage to reach many people together, many learners together. So you could record in a simulation center one or more clinical scenario, or a specific, you could address specific topics and then share the issues with as many people as you want, and also record and also review the scenario as many times as you want. So virtual simulation really works. Also, you can connect as many people as you want live with a simulation center or with an in situ simulation. Actually, we are doing something like this for the pre-hospital stroke code here in Milan, in a very big simulation center with many EMS people connected by in different spokes. So the hub is the simulation center where we are conducting the scenario, the pre-hospital stroke scenario, and there are many spokes connected where they can see the scenario, and also the debriefing has made in the plenary collectively. There are many ways to use virtual simulation, actually.
Thank you. Houman, could you answer the question as well?
Yeah, thank you for the question. Yeah, we have not done too much virtual, but what we did do is still continue with simulation, mostly in situ. And we then had an opportunity to bring some pre-hospital providers on the time when they're not on duty and students into the emergency department and actually run the sim in the real environment rather than in a sim center. And that's just due to COVID, but normally we would also utilize it. It's a great idea. I think that as Dr. Santalucia said, we could use some of this stuff for the pre-hospital, like the phone calls, how you accept a phone call, how do you give advice, how do you organize transfer, especially if it's a bit longer or the patient's unstable. I think there's really good roles for that. I know that residents in our program have voiced interest in wanting to learn about that. So it's a great topic, and I think there's more to explore there with virtual simulation.
Yes, I agree. The topic is excellent, and we have many more questions from the floor. However, due to the time limit, we have to wrap it up, and I would like to tell the audience that if they have questions, they can post them to the World Stroke Organization and the World Stroke Academy. We will be happy to forward them to our speakers and then post the answers on the website of the World Stroke Organization and the World Stroke Academy. So now I would like to thank again our two excellent speakers, the audience for the questions and for the discussion, to thank the World Stroke Organization and the World Stroke Academy for organizing this webinar. And thank you all, and bye-bye.